Hello, I'm John Baille from the Gastrointestinal Endoscopy Editorial Board, and here today to interview the author of an upcoming paper in GIE. And this is Dr. Mohammad Yaghoobi, is that the correct pronunciation?
Yes,
who's second year fellow in the program in Montreal. And he's the first author of a paper whose senior author is actually a former fellow of mine, Alan Barkin, a very well-known outcomes researcher. And the title of your paper, correct me if I'm wrong, is Laparoscopic Heller myotomy versus pneumatic dilation in the treatment of idiopathic achalasia, a meta-analysis of randomized control trials. Am I right with the title?
Yes, definitely.
So the first thing that grabbed me when I read this was how few studies you actually included. You looked at 161 studies starting in 1966 going on to 2012, and you only picked 3. How come?
Exactly, because when you search the literature based on your keyword, you end up having a lot of included basically studies in your search. But based on our exclusion and inclusion criteria, they were the only studies that were actually answering the question that they were looking for.
That's a good answer. So these were the best studies in the field, okay?
Exactly.
So as I read it, the things that came out of the study were, first of all, the response rate of laparoscopic myotomy was a little higher, 86% versus 76% for pneumatic dilation as a balloon, is that right?
Exactly.
Balloon dilation. And the other thing, so there was a high response rate, there were some fewer tears, which is good, you don't want complications.
Definitely.
But there really was no difference in things like the rate of acid reflux, in the quality of life after it, and in what the final lower esophageal sphincter pressures were. Is that correct? I'm old enough to remember when we did pneumatic dilation with a thing that looked like a spear with a big brown bag in the end of it, and people screamed and yelled even under Valium, and it was a terrible bloody mess at the end. Is it like that today, or is it?
It's probably a better tolerated procedure now on. We have better sedations, and also the pneumatic dilator are better designed now as well, and the dilation is done graded now as a standard of care.
Is the conclusion from this study that we should be really sending patients who need this to a laparoscopic surgeon, or do you think there is a role for balloon dilation as a first line and then laparoscopy as a backup?
But this was just an efficacy analysis, basically. We haven't done a cost-effective analysis to see if we can, in a broad range, advocate the laparoscopic Heller myotomy as the first-line treatment. That would be the next research to answer that question precisely. But for now, the only thing we know is in short term, and based on other publication in long term, laparoscopic Heller myotomy just provide better response.
Well, that's a good answer to that. So thank you very much for writing the paper, and thanks for coming today to talk to us.
Thank you for inviting me. Thank you very much.